and also President of Bangladesh Ophthalmic Research Forum. So, Dr. Shirisha Senthil is here, Dr.
Yes.
Ronnie George here, Professor John Brooks,
Yes.
and Dr. Bonita Pathak Ray. Everybody has
Okay,
come.
fine.
Dr.
All are in
Salman, Professor
time.
Jakia. Okay.
Yes.
Okay.
Speakers and panelists all are,
All are.
in time, before time. Thank you very much.
Yes, sir.
So we'll start in time. Before
Yes.
that, I think all of us were in good health during COVID period, as because all were in tension. Even though all ophthalmologists probably in such a situation that they can be attacked anytime, as because we all know that in Wuhan, Li Wang, who first noticed about this virus, isn't it?
Yes.
Yeah. So we should be well protected.
Sir, our plan is
Yes.
actually after each speaker, we will have a discussion time,
Yes.
and then second speaker, then again discussion time, then third speaker, then discussion time, and after that we can discuss. We have, if you have time, then we will discuss with different issues.
Okay. Okay. And I hope after each speaker's topic, panelists will say something about
Yes.
the topic, and if
Yes.
any question, they will also, the speaker will answer the question.
Yes.
Okay.
নুমান, আমি যদি ফেসবুকে দিতে চাই, শেয়ার করতে চাই, কি করতে হবে?
এটা ওই আমার পেজে শেয়ার হলে আমি আপনাকে শেয়ার করে দিচ্ছি আপা।
সেটা ভালো।
এটা এখনো শেয়ার এখনো হয়নি।
তুমি শেয়ার করলে আমি শেয়ার করব। হ্যাঁ,
জি জি জি, হ্যাঁ।
we are live now, sir.
আপনি কি শুরু করে দিয়েছেন? So sir, we can start now.
Yes, yes. We should start now in time.
So slide is visible?
Yes.
yes.
So good evening to everybody. Welcome to the Glaucoma Management Episode-2 session, and we have told it a light behind the darkness. In this session today, our host and chairman, I want to introduce him. He is Professor Mohammad Sharfuddin Ahmed, Professor and Chairman, Department of Community Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He is the President, Ophthalmological Society of Bangladesh, President, Bangladesh Community Ophthalmological Society, President, Oculoplastic Society of Bangladesh, Past Secretary General of BMA, and President, Bangladesh Ophthalmological Research Forum. I'm really delighted to introduce Dr. Borun Kumar Naik sir. He's the head of the Ophthalmology Department, PD, Hinduja National Hospital and Medical Research Council, and he is President-elect All India Ophthalmological Society. And now he is also Secretary, Glaucoma Society of India. Our next panelist, Dr. Ronnie Jacob George, is the Research Director, Deputy Director, Glaucoma Service, Medical Research Foundation, Shankar Netralaya, Chennai, India. Our respected another panelist, Dr. Salma Parveen, she is the Associate Professor, Department of Ophthalmology, Greenlight Medical College, and she is the Secretary General of Bangladesh Glaucoma Society. This is Professor Dr. Vedya Archini Viogo as a panelist. She is the head of the Glaucoma Center, Jakarta Eye Center Eye Hospital and Clinic, Indonesia. Our next panelist, Professor Dr. Zakia Wadud. She is a consultant, Glaucoma, Bangladesh Eye Hospital and Institute. Our first speaker, Dr. Vanita Pathak. She is the Director, Glaucoma, Center for Sight and New Retina Eye Care Institute, Hyderabad, India. Our next speaker, Professor Dr. John L. Brooks. He is a consultant, Moorfields Eye Hospital, London, Great Ormond Street Hospital, United Kingdom. Our next speaker, Dr. Shirisha Senthil. She is faculty and head, VST Glaucoma Center, LB Prasad Eye Institute, Hyderabad, India. And as a moderator, I am Dr. Shams Mohammad Numan. I am senior consultant and head of the Glaucoma, Chittagong Eye Infirmary and Training Complex. And thank you, everybody. And we can start our session. I'm requesting Dr. Vanita Pathak to come with her presentation. And her presentation topics is angle closure glaucoma, passing the crossroads. Dr. Vanita Pathak, now the time is yours.
Thank you very much. A very good afternoon and a very good evening to all who have joined here. For all my friends in Bangladesh, I would like to say a few words in Bengali. আমার বাংলাদেশি ভাই বোনেদের জানাই আমার হায়দ্রাবাদ আর ভারতবর্ষে প্রীতি আর শুভেচ্ছা।
Thank you.
Okay, so hang on just a minute. I just checked all my slides. Okay, here we go. Okay, so my topic is angle closure glaucoma, and I'm going to talk not only being at crossroads, but also its management with cutting edge technology. So when I envisaged this talk, I did not want it to be didactic at all. I just wanted you to take you through a few cases and see how we manage them. So these cases may not be unique, but as we go along, you will see what we are talking about. So the first one is a bilateral shallow AC in routine cataract surgery, and may not be very uncommon actually. This is a 63-year-old lady, systemically quite unwell. She was referred with raised intraocular pressure 9 days after she had her cataract surgery in the left eye. Right one was done 2 months ago. Both were routine surgery. When I looked at the biometry, I found that the axial length was a little bit less, as well as the patient was hypermetropic. When she presented to me, her pressures were 21 and 41. Discs were all right, but what intrigued me was the goniotomy because it was closed and indentation was difficult at the time. So our differential at this stage could be primary angle closure simply, or a plateau iris syndrome, but to diagnose this we need laser peripheral iridotomy, and it could be aqueous misdirection also, but we need a laser peripheral iridotomy to determine that. So we did ultrasound biomicroscopy, and as you can see, it did show an anteriorly positioned ciliary process, absent iridociliary sulcus. Now, this could mean, either plateau iris syndrome or even aqueous misdirection. So the first step was to do a YAG laser peripheral iridotomy. I did a hyaloidectomy with it. And once this was patent, I dilated the pupil and I did a peripheral capsulectomy. She was put on steroids, atropine, and she was asked to continue with her anti-glaucoma medication in the left eye. Her visual fields were normal. When she came back 4 days after her laser, both her ACs were deep. Pressures were controlled in both eyes, but when I did the gonio, right eye seemed open right up to scleral spur, but the left eye appeared closed 360 degrees. She was asked to discontinue her atropine and steroids tapered, Combigan continued in the left eye. I asked her to come back for a routine follow-up, but she came back 3 days later with blurred vision and pain in the left eye. Left appeared to be shallow once again. The right was okay, and the pressure in the left eye was high once again. So in my mind now, the diagnosis was pretty clear that in the left eye, she was suffering from aqueous misdirection. Now, at this stage, the patient and the family were very concerned because they were due to go overseas within a few days and they had thought that they'd get the cataract surgery done and then go. But unfortunately, that did not happen. She was complaining bitterly about the blur with the atropine. She did not want to use it long term. She did not want to use anti-glaucoma medication on a long term because if you remember systemically, she was pretty unwell and she did not want any more medications added to her repertoire. So here we are. We had to take the surgical route. She almost bent my arm. So what did I do? I did a left eye trabeculectomy with an ostial iridozonulohyaloidovitrectomy with primary posterior capsulectomy. Sounds like a mouthful, but actually it's pretty easy. By the time you say it, you can do the procedure. So I'll take you through a short video where I have done the procedure for her. I hope
she underwent a trabeculectomy, and through the ostium and iridectomy created, she underwent a zonulohyaloidovitrectomy with primary posterior capsulectomy. Preoperatively, her anterior chamber was deep as atropine was recommenced. She also received mannitol to detergest the vitreous. Under peribulbar block, a standard rectangular flap was raised. Anterior chamber was entered and ostium punched and iridectomy performed. Anterior vitrector was then inserted through this ostium and iridectomy to cut the zonules first. This was followed by rotation of the vitrector into the anterior vitreous, and hyaloidectomy was deemed adequate when a primary posterior capsulectomy was done. Sustained deepening of the anterior chamber was the end point. Post-operatively, this eye did very well. The AC remained deep and the IOP controlled without medication till last follow-up.
So yes, she did very well. Her pressures were controlled. Her vision was 6/6, and she was pretty happy that she didn't need to use medication anymore. As you can see at last follow-up, when she came, her left anterior chamber is deeper than her right, but her right pressure is controlled. So there's nothing that we are doing just yet for the right eye. She had a diffuse bleb, posteriorly directed bleb in the left eye with controlled pressure. So my second case is a unilateral now, shallow AC post laser peripheral iridotomy. So this patient now has been referred after laser and has high pressures in both eyes. In the right eye, and he's not controlled on medication and vision is only count fingers. So he's shallow in the right eye, he's deep in the left eye, this is post-laser, and pressures raised in the right eye. When I did a gonio, it was closed on the right side with a posterior push type of mechanism, and left eye was open. This was nothing to comment about. Before doing a UBM, pupils were inadvertently dilated, but the differential that I considered here was definitely a lens-induced one. I thought it was subluxation. He denied trauma vehemently until after his UBM was done. It could be a ring iridociliary cyst, or it could even be an aqueous misdirection induced by LPI. This has been noted in literature, or could simply be plateau iris syndrome, but it is usually bilateral. So when I did the UBM, as you can see there, the entire lens was delivered into the AC. So it was obviously subluxated and is now completely dislocated into the AC. And the PI was patent. So management options here, retroplacement was not possible despite maximal pupillary dilatation in the supine position. So you're worried about corneal decompensation, you're worried about further rise in intraocular pressure, and there's also a slight risk that if it does go back, then there might be a posterior dislocation. So you have to remove the lens, there's no doubt about that. But do we need to do filtration with it? Phaco obviously is not possible, and I didn't want to do large incision surgery for him, not only compromising the conjunctiva, but also possibly the sclera. So I planned for two-stage surgery. What I did in the first stage was I removed the lens with an anterior retractor, and the only incision that we used were 2 paracentesis, and then reassessed post-operatively and to see whether filtration was required along with the flanged IOL. So here is the first stage surgery where only 2 paracentesis were done at 3 and 9 o'clock position. Viscoelastic was used liberally, not only to levitate the lens, but also to coat the endothelium, and a retractor was introduced, and the lensectomy was done. As you can see there, I'm just fast forwarding it for your benefit. And an anterior vitrectomy, a thorough anterior vitrectomy was also done. Following this, the second stage surgery was when I did a trabeculotomy, raised a rectangular scleral flap first, and then used an ACM. You'll see that just now. Yeah, used an ACM, and then did the markings for this flange sclerofixated IOL. It didn't come out very nicely in this one. Made a keratome incision through which a 3-piece, multi-piece IOL was inserted. It fed into, the haptic was fed into the needle through the intrascleral canal and exteriorized, as you will see there in a minute, or in a few seconds really. And the tip was cauterized to create a terminal bulb. And similarly on the other side, micrograspers were used to feed the haptic into the needle and exteriorized as it was done in the on the other side, and a terminal bulb created. Then trabeculectomy was completed, entry of AC, punch, all this I don't need to show you, as well as suturing, and finally conjunctival suturing. I do 10-0 vicral, conjunctival edge-to-edge suturing. Okay, next. This patient now has about a year's follow-up, is 6'6" in that eye, N6 with correction. AC is deep, IOL is stable, pressure is normal with no medication. So he too is a happy bunny. Third one is a little intriguing. It was acute on chronic angle closure glaucoma, whereby patient presented with pain and corneal edema, blurred vision and corneal edema, was referred from as phacolytic glaucoma and was already given mannitol. Patient's vision was count fingers in that eye. There was a corneal edema, but there was no intumescent lens, neither was there any mature lens. There was some sphincter ischemia, but there was no block. And this was confirmed with UBM later. Her pressures were 36 at that point. And on gonioscopy, she was closed in the left eye with 4-quadrant peripheral anterior synechia. Right eye was completely open. As you can see, the depth of the anterior chamber between the two eyes was not very different. The left one though was closed. And she did have quite a bit of disc changes in the left eye. So because it's unilateral, we exclude primary angle closure glaucoma here. Lens was neither hypermature nor intermittent, so it's not lens induced. Could it be inflammatory? Could it be neovascular? Or could it be a ring cyst? All her investigations came back normal. Only the UBM gave us the clue that she did have a ring iridociliary cyst in the left eye, and she also had a very small minor remnant, cyst in the right eye, not causing any kind of change. So we managed with topical steroids, we strengthened the anti-glaucoma medication, but still, she was still uncontrolled, as I suspected the compliance was extremely poor. So we had to take the surgical route yet again. So here we are. What did we do? We first took the lens out and put the IOL in the bag, and then used an endoscope. Here, the first thing that hits you if you do endoscopy is the very irregular ciliary processes, and the fact that it is raised almost on a platform with several very thin-walled, very ragged, irregular cysts within that particular zone. So endoscopic laser was used, targeting the posterior tail of the ciliary process and avoiding all those cysts. So it did not lead to any kind of rupture. I'll show you yet another video whereby you can see how regular the ciliary processes actually look, as well as what a difference it can make in plateau iris syndrome. So again, after the lens is in the bag, you first introduce the endoscope into the AC. You can see that only one clock hour is open. After that, you go behind the iris into the sulcus, and you see these very regular, juicy ciliary processes. Here I am doing laser to the tip yet again. See how regular they are. See how you need to avoid pops as seen there. And through a phaco wound, you can do about just over 2 quadrants. I reintroduce the endoscope in the AC, and you can see just how widely open the angle has become now after the laser has been done. So on the left-hand side was prior to laser, on the right-hand side after laser. Even in pseudo-exfoliation, when you use this, just there is absolutely no snapping of the zonules. You can see that all zonules absolutely fine because you're targeting under direct vision. Okay, we'll stop there. So this patient also did well, although in the initial postoperative period, she did have mild fibrin. This was managed conservatively. She regained good vision by a week. Her AC remained deep. IOL was in situ. She had advanced loss. As I told you, the disc changes were quite marked. She also had cataract surgery in the left eye, and she regained good vision in that eye too. Till last follow-up, her pressures were controlled without medication. And UBM was repeated. You can see there is a remnant of the cyst, I shouldn't call it tumor, at 6 o'clock, and you can see the angles are closed. So angle closure glaucoma is very fascinating. There are several aspects to it, but when it is primary, it is usually bilateral, though it could be asymmetrical. And the EAGLE study has recently endorsed cataract surgery in angle closure, but when it is done, I would suggest that there is a careful assessment of the anterior chamber depth prior to dilatation, that we can have a primary angle closure in the absence of disc changes. And the biometry should be carefully evaluated. Not all dilated primary angle closure will have an acute attack, and mere LPI probably would have stopped all these interventions in this particular case, where you're always worried about possible litigation. On the other hand, unilateral angle closure is usually secondary. We have to actively seek the cause. Even if there is no definite history of trauma, you cannot disregard it as the etiology. And in the third case, use of endoscopic laser versus the transscleral diode avoided potential rupture of the cyst and subsequent inflammation. So what I would say, by saying, is that ultrasound biomicroscopy is the investigation of choice in all such cases. And even at crossroads, cutting edge surgery, technology, and appropriate management of each case resulted in favorable outcome, leading to lightness after the darkness. Thank you very much for a patient hearing.
Thank you very much, Dr. Vanita. It's an excellent presentation and excellent video displaying, and especially your ECP and the cyclophotocoagulation video. That is really very nice. And now we can discuss on this matter. I'm requesting Dr. Varun Kumar Naik to tell something about her presentation. And what is your comment about that angle closure glaucoma and management?
Thank you very much. And it was really a lovely presentation and showing some unusual cases and bringing out some important point. As he rightly said, that in case if it is bilateral and unilateral, then you have to think of something different, that it's not a routine case of primary angle closure disease, something like that. So that's a good message that she has conveyed. And fortunately, in all cases, the outcome was good. But in first case, I thought probably it was, I don't know, maybe the trabeculotomy which was done along with the vitrectomy and anterior hyalurectomy and zonulectomy, I thought probably because I basically want to go step by step. So I would have preferred first doing only those, and then in case if it's not improving, chamber becoming deep, if it's not reducing pressure, no, it's okay. You can. So then maybe that trabeculotomy we could have. That is just, it's my thought process. But otherwise, he has brought out very good point, and definitely without any question, the UBM, because the difference between anterior segment OCT and UBM is that you can see behind the iris what is happening, which otherwise you cannot see. Means exactly what is happening at the ciliary sulcus or at that location. So that way UBM is a good investigative tool, but it is not a replacement for and not a must for all ophthalmologists who are doing some glaucoma surgery. That it's an instrument difficult to have. But for someone in a specialized center, it's a good tool, and it's a very nicely she had explained the utility of that.
Okay.
Thank you,
Can I just make a point?
Yes.
Oh, yes.
Right. So there were two things here. One was definitely that she had 360-degree angle closure, and that was synically closed. So it probably was unlikely that she would be controlled without medication. That was one point. Second is, yes, the patient is probably always better to go step by step, but you're taking the patient for 2 surgeries, whereas in this particular case, just one surgery killed both the problem. With the trabeculectomy, as you can utilize your ostium as well as the iridotomy to go into the zonules and clear out the anterior vitreous, it just helps to reduce another incision, basically. So that was my thinking, my logic. And of course, the time factor was very short for this particular patient. We have to keep everything in mind. This patient was very angry that she had only come for cataract surgery, and my colleagues then passed her over to me, saying, please manage,
Thank you, ma'am. I have one question actually about the endocyclophotocoagulation. What is your comment about the first-line surgical procedure of any kind of glaucoma? If we some studies shows that the ECP can be used as a primary surgical procedure. What is your comment about that?
I would fully agree. I am of the opinion that it is, especially if you're doing cataract surgery, the combination of cataract surgery with endocyclophotocoagulation is extremely simple and can be as first step. I can tell you my experience, and I just published it in Ophthalmology Glaucoma, is that when I used it in pure angle closure cases, it fared equal with phacotrap. But on the other hand, there were far less complications and far less interventions for those complications. So I will actually put it above trap. If I were to develop, let's put it this way, if I were to develop angle closure glaucoma, hopefully not, because I'm a myope, but I would not prefer a trab at all, an uncontrolled glaucoma. I would definitely like something which is less invasive, and this is less invasive, minimally invasive surgery. The phaco wound is utilized. You're not making any other wound for this laser.
Dr. Ronnie George, what is your, yes, Dr. Salman, please.
Thank you, Dr. Anita, for your excellent management of 3 cases. I have one question regarding the second case. This is a dislocated lens in the anterior chamber. Actually, this dislocation before LPI, it was not diagnosed before doing LPI, but how did you miss that diagnosis?
No. See, I did not do the LPI. The patient had LPI done elsewhere and then referred to me because the pressure was not controlled. But nobody told me that there was a differential in the AC depth. That is what we discovered. Since the patient denied a history of trauma, and unfortunately because the patient got dilated prior to UBM, what happened is that the lens completely dislocated into the anterior chamber, and so had to take up the management from there. Yeah.
So thank you for your excellent management of that case.
Thank you.
Okay, thank you.
Dr. Rani George, do you have any comment about this ECP and angle closure glaucoma? What is your experience? And
yeah, so thank you, Dr. Shams. Excellent cases and very well managed. Regarding the ECP, I differ a little bit from Dr. Vanita, because I still feel that I would hesitate to do a cyclodestructive procedure in somebody where there are other options available. The one possible exception to that would be somebody with very significant plato iris, where I think it might help me to open up the angle. Otherwise, I tend to prefer conventional surgery to doing an ECP in these cases. One of the reasons is a lot of the studies which have been done, the surgery has been combined along with a phaco. And phaco alone, we know, can do fairly well in controlling intraocular pressures in people with angle closure. And given that there are multiple case reports of sympathetic ophthalmia following a diode cyclophotocoagulation, I would hesitate to do something targeting the ciliary body in somebody who has, let's say, mild to moderate angle closure disease.
Thank you. Professor Sharfuddin Ahmed, do you have any comment about this presentation?
Very nice presentation, Dr. Vanita Pathak. I want to know one thing for the residents. What are the conditions, or what is the raised intraocular pressure condition we use the atropine? You also mentioned here in some cases. Can you explain how we can control glaucoma with the use of atropine?
Well, actually, atropine in angle closure would be indicated in one and only one condition, whereby pressure is raised with a uniformly shallow AC in the presence of patent peripheral iridotomy, because that is suggestive of aqueous misdirection or malignant glaucoma, as some people want to call it. Atropine helps to pull back the iris lens diaphragm and deepen the AC. As you saw in this case also, with atropine, it magically went back.
Yes, thank you very much for your nice presentation. I think this will help many of our glaucoma specialists for managing this type of difficult cases. Thank you.
So now I'm requesting Professor John L. Brooks to present his presentation. This is on the angle surgery in the childhood glaucoma. Professor John Brooks.
Thank you. Thank you. I will just try and share the content. Are you able to see the screen?
Yes, sir.
Good, thank you. Well, Dr. Shams, thank you very much for the invitation. I had a fantastic time in Chittagong when I came in February, which I think was just before lockdown, so I got the opportunity to come and see you there. But I'm afraid I'm not going to say any words in Bengali because I think I might embarrass myself. Anyway, so I'm going to talk about angle surgery in childhood glaucoma. And I think this is a very important subject because I think with increasing, with the improvement in techniques that we have with angle surgery, we can really avoid a lot of the future problems that we all worry about in children who have glaucoma. Just to remind ourselves about the classification, because this is important in determining which children that we operate on. We classify childhood glaucoma into primary childhood glaucoma. The most common is primary congenital glaucoma, or PCG, and juvenile open angle glaucoma. The secondary glaucomas, as you'll be aware of, we can subclassify that into 4 categories. Glaucomas associated with congenital ocular anomalies. And these are conditions like anterior segment dysgenesis, for instance, where the main phenotype relates to the eye, although there can be some systemic features, but the main disease is ocular. We have glaucomas associated with congenital systemic diseases. So these would be conditions like Down syndrome or Sturge-Weber syndrome or neurofibromatosis, where it's essentially a systemic disease of which glaucoma can be part of it. And then we have glaucomas associated with acquired conditions, and these are things like uveitis. So these are not present at birth, but develop in later childhood. And glaucoma following cataract surgery gets its own classification because it's the most common secondary glaucoma in children, and arguably the most difficult to treat also. And with primary congenital glaucoma, these are isolated angle anomalies, and we can further subclassify these into the age of onset, neonatal, infantile, or late onset. Now, the reason I want to talk about angle surgery in children is that we want to avoid further incisional invasive surgery because we've got the whole life of a child to manage. And children who have trabeculectomies with high dose of anti-scarring agents like mitomycin, children who have glaucoma drainage implants where there's a lifelong risk of conjunctival exposure, infection, intraocular endophthalmitis. If we can do a procedure at the start of the patient's pathway and avoid these other operations for as long as possible, that would be a great benefit. Because we also know that glaucoma surgery in children is more complex, it has a higher failure rate, more complications. Success rates for secondary childhood glaucomas are slightly less than for primary congenital glaucoma. But I think it's increasingly shown that some of the angle surgeries we can use in secondary glaucomas, which do have some benefit and may well avoid more invasive surgeries even in these other secondary glaucomas. Now, when we're talking about angle surgery, we'll be aware of the most traditional of all, which is the goniotomy. And the goniotomy has been around since the 1940s. And this really revolutionized the treatment of childhood glaucoma because prior to the development of goniotomy, there was very little that could be done for children with congenital glaucoma. And so this controlled many children for decades and has been a real game changer. Trabeculotomy was developed in about the 1960s and very familiar with the traditional trabeculotomy using a rigid probe. But more recently, there's been the development of a circumferential trabeculotomy or 360-degree trabeculotomy, either with a proline suture or illuminated microcatheter. And I think, again, that's revolutionized further the success rates of childhood glaucoma. Now, the indications for angle surgery primarily is primary congenital glaucoma. And this has the best outcomes of any of the childhood glaucomas. And we'll talk about some of the success rates in a moment. But there are numerous papers looking at some of the most common secondary glaucomas like Sturge-Weber, aphakia, uveitic glaucoma, aniridia, and so on, which have used angle surgery with good outcomes and have avoided or at least postponed the need for further incisional surgery. And I found that in juvenile onset glaucoma, we do get very good outcomes from trabeculotomy surgery, and more recently the 360 trabeculotomy. Now, as I mentioned, goniotomy has a long history, first developed by Barkan, who described Barkan's membrane. He also developed the goniotomy procedure in the 1930s. And until recently, we were using goniotomies from about 1947 at Moorfields. And you can see from the original drawing in the publication, it's changed very little, where a tapered goniotomy knife passes across the anterior chamber and incises the angle just above the insertion of the iris. And you can see that there's a posterior dropping of the iris, which allows the opening of Schlemm's canal. And you can see from these photographs, this is the same patient. He comes with unilateral primary congenital glaucoma in the right eye. And many years later, he has very good pressure control with no drops, clear corneas apart from the hard striae, but you can see also has a healthy optic nerve. Trabeculotomy also has a long history. This chap called Redmond Smith described trabeculotomy using a suture in 1960. And Burian in the 1960s also described the traditional trabeculotomy using the rigid trabeculotomy probe. And so all of these procedures have been done for many decades quite successfully. However, from the 1990s, Beck and Lynch described the 360-degree trabeculotomy using a 6-0 Prolene suture. And what really advanced this procedure was the development of the illuminated microcatheter, because it's very important to visualize the tip of the catheter. And so you're able to see whether the catheter remains in Schlemm's canal or whether it's deviating down a collector channel or sub-retinally, which obviously needs to be avoided. Now, what you can see here is the illuminated microcatheter being patched into Schlemm's canal, and we can see the tip of the red light flashing, so we know that we're in exactly the correct position. And here there's a short video. So this procedure is done in the inferotemporal quadrant. So again, if further surgery is required, the superior conjunctiva is free for any further surgery, such as trabeculectomy or tube implant. So I tend to do a triangular partial thickness scleral flap and trying to make the flap as deep as possible, because this makes the identification of the landmarks and identification of Schlemm's canal more easy. And what we're looking for is the transition between the cornea and the sclera. And you can see the probe just slips nicely into Schlemm's canal when you know you're in the right position. So we make a paracentesis because we use some myocol to constrict the pupil. This protects the lens. And then we fill the anterior chamber with a viscoelastic, and which stays in at the end of the procedure. Now, it's very speeded up video, but the catheter passes through 360 degree and is retrieved from the original entry site. And then in a moment, when we pull the two ends of the catheter, you'll see the catheter within the anterior chamber, tearing the anterior wall of Schlemm's canal through 360 degrees. And so it's angle surgery treating the entire angle, whereas goniotomy or traditional trabeculotomy only treats about a third of the angle at most. And this is the great benefit of 360 degree trabeculotomy. The other great benefit is that it only has to be repeated once. If goniotomy fails or trabeculotomy fails, that might need to be repeated. Well, let's have a look at the outcomes. So these are a couple of papers comparing the 360 degree trabeculotomy to the goniotomy. And you can see that in the trabeculotomy group, IOP successfully controlled in over 90% of cases, compared to 58% of the goniotomy group. Visual outcomes are better. There's less of a degree of high myopia prevalent in the trabeculotomy group, and the follow-up's greater for goniotomies. And you can see using the illuminated microcatheter in the second study, the qualified success rate is over 90% in the trabeculotomy group, compared with over 54% in the goniotomy group at 12-month follow-up. Now, we've just published our data in the American Journal of Ophthalmology, and we thought it would be interesting to look at the transition between traditional goniotomy, traditional angle surgery, and the 360-degree trabeculotomy. And the idea behind this was, if we looked at our last 50 goniotomies and our first 50 trabeculotomies, we can see we should be at our best, our most experienced at goniotomies, and our least experienced in trabeculotomy. Despite that, you can see the fantastic difference there is between goniotomy and trabeculotomy. So complete success at 1 year was 69% in the trabeculotomy group and only 23% in the conventional angle surgery group, which is the goniotomy. And qualified success at 12 months was 85% in the 360 trabeculotomy group and only 37% in the goniotomy group. So even though we were at our least experienced in the trabeculotomy, we're getting clinically significant improved outcomes with trabeculotomy compared with goniotomy. You can see that pre-2013, which is when I first started doing the trabeculotomy group, the pathway would be angle surgery, goniotomy, and repeat surgery if that fails, before proceeding to a bare belt tube implant. In 2020, we only need to do the trabeculotomy on one attempt because we've treated the entire angle. So there's no need to repeat that sort of angle surgery. And if that fails, unfortunately now it rarely fails, we can then proceed directly to a tube implant. So we're speeding up the pathway if needed. But interestingly, last year I published the outcomes of tube surgery in children I did under 2 years of age. And the number of children needing tube implants now is significantly less because of the improved outcomes of 360-degree trabeculotomy. So in conclusion, angle surgery is still the treatment of choice in primary congenital glaucoma, but increasingly in secondary glaucomas. Traditional goniotomy and traditional trabeculotomy have fairly similar success rates, but when you compare that to circumferential trabeculotomy, we're getting significantly better outcomes than in traditional angle surgery. And it's the illuminated microcatheter which has allowed a safer procedure, continuous visualization of the tip, so we know it's safe surgery, and you can see the improved outcomes. Thank you very much.
Thank you, Professor Brooks, for your nice presentation. I think Shams Muhammad Noman.
Yes, sir.
He has nicely briefed all the things, the latest goniotomy and trabeculotomy. And
Yes,
now we can go to the panel.
Yes, we have a lot of questions
Yes,
in the Facebook and also in different videos. So in the first 2 questions asked by my teacher, respected teacher, Professor Nazrul Islam. He's our president of Bangladesh Glaucoma Society, advisor of Bangladesh Glaucoma Society. He asked Professor John, do you use antifibrotic like mitomycin C in the children? And what is your concentration and exposure time? Professor Brooks.
So, yeah. So I try and rarely use anti-scarring agents like mitomycin in children, just because of the worry of the long-term effects of an anti-scarring medicine. I rarely do trabeculectomy in children nowadays because you have to use a high dose of mitomycin. And you've got then decades of the effect of that anti-scarring medicine on the sclera and the conjunctiva. So there's a lifelong risk of the conjunctiva thinning, becoming avascular, and that opens the eye up to intraocular infections. With tube implant surgery, I find that firstly, there's really very little evidence that it improves the outcomes of bare belt tube implants. But also, when I compared my results when I used to use mitomycin, there was no difference between with mitomycin and without mitomycin for shunts. So I no longer use mitomycin. And obviously with trabeculotomy, there's no need to use mitomycin anyway. So because of all those reasons, I try and avoid anti-scarring agents in glaucoma surgery.
Thank you, sir. And another question, if you do the 360-degree trabeculotomy, what is the percentage of possibility of hypotony in case of children? You know, if there is hypotony in case of children, it is really very difficult to assess. So what is your experience? Is there any possibility of hypotony after 360-degree trabeculotomy?
Yeah, I think the risk of hypotony is very great if you do 360 trabeculotomy, because you're going from a situation where there's little or no drainage through the Schlemm's canal to opening up the entire Schlemm's canal. And in that case, there will be a very high risk of hypotony. So on the video, you saw me doing a paracentesis and injecting some viscoelastic, normally Healon GV or Provisc, but I don't remove that for two reasons. Firstly, that when you complete the trabeculotomy, you'll always get some hyphema. And so if the viscoelastic is left in the anterior chamber, it tamponades the angles, so it stops the hyphema from causing a major problem. But also, it stops the risk of hypotony. When you see children a week after the operation, the pressures on the low side, it typically measures 6 to 8 millimeters of mercury, but the anterior chamber is always deep and there's no clinically significant hypotony. So the idea is that if you leave viscoelastic in, you don't get the complications of hypotony following a trabeculotomy. But if you remove the viscoelastic, that will be a very high risk.
And another thing is, I'm coming to the some interesting questions the attendees are asking. One is, what is the actually in this subcontinent we are doing the trabeculectomy and trabeculotomy both in case of childhood glaucoma. So I think probably you love to do only the trabeculotomy or 360-degree trabeculotomy. So what is your comment about the combined surgery, trab and trab?
Well, traditionally in the UK, we've never done combined surgery. Now, I know that it has very good outcomes in Bangladesh, India, the Middle East, and it's very commonly done. I find it difficult to know whether it's the trabeculectomy that's functioning, the trabeculotomy that's functioning, or a combination. When I've seen children who've had a combined procedure, in my experience, the trabeculectomy is always flat and scarred. So I don't think the trabeculectomy works long term. And also, if you do have a trabeculectomy, you would still need to use mitomycin, which is what I want to try and avoid. So with the 360, I would say that the benefit is because you're not having any limbal drainage. And that's the benefit of all glaucoma surgery apart from trabeculectomy, because we want to avoid limbal blebs because that's the ones that are open to infection. So I've always felt that the primary treatment should be angle surgery. And if that fails, then go along to trabeculectomy, because I'm not clear what's the benefit of combining the two when you see that trabeculectomy is going to fail in the short term anyway, and you've still got the effect of the anti-scarring agent. And particularly with the 360 trabeculotomy, because there's such a good success rate, 80 to 90%, most of the children are going to have to, those children will then not need a trabeculectomy. And so you're avoiding those complications in the long term.
What is your comment, Dr. Vidya Archini?
Yeah.
What you used to do and what is your experience and comment about the presentation?
Yeah. I just want to ask, yeah, Prof, do you do maybe implant tube, yeah, for the children when you have glaucoma for the children?
Yes. So what I would do is that if angle surgery fails, my next line would be a bare belt tube implant.
What kind of tube do you use? I think
so I normally use a bare belt tube. So in children with uveitic glaucoma or aphakic glaucoma or Sturge-Weber, I tend to use a 250 bare belt.
Yeah, 250, yeah.
Whereas in failed angle surgery in primary congenital glaucoma, for instance, I would use a 350 bare belt.
Yeah.
The only reason to use a 250 in the conditions I mentioned is that the consequences of hypotony are much greater. With Sturge-Weber, there's the risk of bleeding. Aphakics are more prone to hypotony anyway. And so if you use a smaller plate size, then you're less likely to get hypotenuse complications. So uveitis, aphakia, Sturge-Weber, I would use 250. Other types of glaucoma in children, I would use 350 bare belt.
Yeah. Yeah, I think same things. I try to do the trabeculotomy first for the, I think for the infants. And then after I fail, so I usually do the implant tube after that.
Yes,
some things.
yeah.
But I
Thank
never
you.
do with the antifibrotic agents. Yeah, same things.
No.
Okay, Professor Jakia Wadud, do you have any comments or any questions about Professor Brooks' presentations? Please
Wadud?
unmute yourself. Unmute yourself, Professor Jakia.
Sorry. Sir, Professor Dr. John L. Brooks, from your experience, sir, would you say the onset of disease and the presentation time that presents to you would affect the outcomes? Because in Bangladesh, we have very late presentations to doctors. So
Yes, yeah.
from your experience, what you say?
I do think it makes a difference. In the UK, we tend to see children very quickly. There's no delay in referral or diagnosis. And so typically, we'll see patients within a couple of weeks of onset of symptoms. And we tend to, particularly for primary congenital glaucoma, we plan surgical treatment within a couple of weeks after that. So treatments carried out earlier, and I think there's a lot of evidence that the more delayed the diagnosis, the worse the outcome. Not so much also in relation to the cornea, because the later the diagnosis, the more scarred and cloudy the cornea becomes, which does make treatment more difficult. Now, the benefit of traditional trabeculotomy and 360 trabeculotomy is that you can treat these conditions even with a hazy, scarred, cloudy cornea, whereas you cannot with a goniotomy. But I think delayed diagnosis is a big issue in terms of the eventual outcomes.
Thank you, sir.
Thank you. Thank you. Professor Sharfuddin Abid, do you have any comments?
Yes, I have a comment on this topic. You have mentioned that in juvenile open angle glaucoma, you were also having some angle surgery.
Yes.
What type of surgery you perform in the juvenile open angle glaucoma, and also in Sturge-Weber syndrome, what type of angle surgery you will perform?
So the angle surgery would be the 360-degree trabeculotomy.
Yes.
So a lot of these childhood glaucomas, the pathophysiology is at the level of the trabecular meshwork and Schlemm's canal. So it makes sense to direct the treatment where the underlying mechanism lies. And that's why, as time has gone on and I've had good outcomes with primary congenital glaucoma, I started treating more secondary glaucomas. But I've had particularly good results with juvenile glaucoma by doing the 360-degree trabeculotomy. And even with Sturge-Weber syndrome, if the glaucoma occurs with an early onset, so in infants, again, I would still do a 360-degree trabeculotomy because, again, the primary pathology is at the trabecular meshwork. There are other reasons in Sturge-Weber, like the raised episcleral venous pressure. But, when you consider the minimally invasive procedures in adults like eye stent and all of these other eye devices, you're only opening a small amount of the Schlemm's canal, whereas with the 360, you're opening up the entire Schlemm's canal. And so I think this is the reason why we're seeing these good outcomes, is because that's where the primary pathology is, and we're opening the entire canal.
Okay. Along with this, you have also already mentioned about the aphakic glaucoma. We are also performing this trabeculotomy. You are also performing it in that?
Yes. Yeah, I think you have to be a little bit more careful because of the risk of hypotony. That's always the case with any sort of surgery with aphakics. But again, one of the big questions in aphakic glaucoma is what the underlying mechanism is. And recently there have been some ultrasound biomicroscopy studies looking at Schlemm's canal, showing it is actually abnormal compared to children without aphakia. So again, the pathology might lie within Schlemm's canal and trabecular meshwork and the outflow pathway. And so that's why there's still a benefit in doing a trabeculotomy in aphakia. And if it avoids doing a cyclodestructive procedure or a trabeculectomy, which has very poor outcomes in aphakia, or a tube implant, and we've avoided in a certain proportion of children doing these other procedures, then I think it's worthwhile attempting trabeculotomy.
Thank you. Thank you very much.
Thank you. Thank you, sir. I think we will go for our third presentation. And after that presentation, we will have time to a lot of discussions and share our experiences. Now, I am requesting Dr. Sirisha Central for her presentation, Tips and Tricks of Safe Implant Surgery and Surgical Modifications of Implant in Complex Glaucoma. Madam, the time is yours now.
Yeah, thank you, Norman, and good evening to all. So I will share some of my experiences and possibly some tips that I learned in doing this complex glaucoma surgeries with implants. I would like to dedicate my today's talk to Dr. B. Sridhar Rao, who we lost yesterday, who is a great academician and a fantastic human being and a great teacher. And the reason why I would like to dedicate this talk to him is because he was the one who first assisted my implant surgery way back in 2005. And that is how my journey started in this field. So when we see eyes like this, it's very easy for us to say that several of them have poor or nil prognosis and they are inoperable. I don't think we'll be able to manage cases like this. However, today these eyes are operated on thanks to our excellent cornea and retina colleagues. So they do a fantastic job. There are multiple interventions that are available today. Rarely do you see a condition where they say that nothing can be done. Having said that, these eyes, because they are of their complexity that is there, they have either a very high degree of pre-existing glaucoma or a high incidence of glaucoma that develops later on. So most often they are medically uncontrolled and we need to resort to surgical management in these eyes. So what do we do in these eyes? And of course, the implants are definitely the choice in these cases. And in our experience, we do not have Molteno and Bawelt with us. So we have experience only with Ahmed glaucoma valve and Adi, which is similar to that of the Bawelt prototype. Affordability of these glaucoma drainage devices, again, is a major problem. And in India, if you see, close to 20,000 rupees is the cost of an AGV, whereas it is less than 5,000 rupees for an Adi. So there is absolutely no comparison as far as the cost is concerned. And we know that that has a lot of implication. And also the long-term intraocular pressure control is obviously much better with Adi. But like I said, our experience is much more with an AGV where we know that it is quite safer to do the procedure, but we do deal with the long-term high IOP related problems. Whereas with an Adi, technically it is slightly difficult, but once we learn it, it's not very difficult. But yes, post-operative hypotony is something that we all have to learn to manage. So this is a commonly asked question that several times people ask, when do we choose a valved implant and when do we choose a non-valved implant? So to me, the answers are, how soon do you want the pressure to be controlled? How much of intraocular pressure control does this eye require? Can the patient come back for a review or a follow-up? This is to me the most important one. And of course, associated ocular and systemic comorbidities. All of us will agree that planning for surgery is the most important one as far as the implant surgery is concerned. Technically, the surgery is not very difficult. Like you know, in most developed countries, the residents do the implant surgery first and then later they learn to do a trabeculectomy, because trabeculectomy is more skill-oriented and it is a little difficult surgery to operate as well as to manage in the post-operative period. However, planning is very, very important to get a successful surgery as well as to decrease the rate of complications that are associated with implants. Starting from the size of the eyeball, the mobility of the conjunctiva, the health of the conjunctiva and the sclera, the condition of the cornea and other surgeries that the eyes have undergone, depth of the anterior chamber, presence of synechiae, presence of anterior chamber intraocular lens or other problems that are there in the anterior chamber, peripheral anterior synechiae, lens position and lens condition is very, very important. And of course, what is there in the vitreous, and do we need to plan additional procedures during the time that we do a tube surgery? So meticulous surgery is very important, but I think I would actually play more emphasis on choosing the appropriate type of implant, choosing appropriate size of the implant, doing implant surgery in a location that is safe for the patient in the long term, and position of the tube in the anterior chamber. I think these are things that we all of us intuitively plan, but I guess as several people begin to do the surgeries, if these are the things that are kept in mind and preoperatively assessed, it will help them to do a successful surgery and a safe surgery. Location of the implant most often is superior-temporal because of the inherent advantages of the lid covering the position, as well as the good accessibility, as well as the procedure itself becomes quite easy because the maneuverability, everything becomes quite easy. However, we choose other locations based on the health of the conjunctiva, the scleral health, as well as the space in the anterior chamber. So I'll just take you through a few cases. 51-year-old lady who had multiple previous vitreoretinal surgeries, and the vision was 2400. This was her only seeing eye, intraocular pressures of 35 millimeters of mercury with a previous failed trabeculectomy and transscleral cyclophotocoagulation. This patient was referred to me, and we chose to do an inferior location implant, and a tube was placed in the sulcus. And she did have a superior-temporal staphyloma that was also kind of taken care of during the procedure. And this patient, 1 month later, had vision of 2320. That was the best that she could see in the past few months. Intraocular pressures maintained at 16 millimeters of mercury on anti-glaucoma medications. The reason why I thought I should share this video is that sometimes when we know there's a failed TRAB and a failed TSCPC, we say that yes, we may try to do one more DLCP, but then, you know, this is a seeing eye and this is the only seeing eye for this patient. So even in these conditions where previous surgeries have failed, implant surgeries definitely have a role to play. But having said that, choosing the appropriate implant and choosing the appropriate location and managing the associated problems that are there in the eye will take a long way in helping these patients see better. How do you open the conjunctiva? This is again a very commonly asked question, and all of us are at a crossroad when we see scarred conjunctiva. So I would like to classify the scarred conjunctiva into anterior scarring as well as anterior to mid scarring. So if I say anteriorly scarred conjunctiva, about 1 to 2 millimeters from the limbus, it's not very difficult to manage these eyes. So this is one such patient, a 16-year-old boy post-cracker injury, severely bruised ocular surface, had to undergo ocular surface reconstruction, literally 14 intraocular surgeries and extraocular surgeries put together before he underwent a Boston keratoprosthesis. Fortunately for him, his vision improved to 20/25. And of course, since these eyes are involved, have a long chance of developing glaucoma, this boy also developed glaucoma. He had severe symblepharon, literally no fornix. So what we did was try to open up the scarred conjunctiva along with the symblepharon and used a smaller sized AGV to fix it, covered it with a patch graft. And what is important is that meticulous conjunctival closure. So extremely cautious, both with the vicryl as well as the nylon. The entire anterior conjunctiva was closed. And most importantly, we did a tarsorrhaphy along with it, so that each time the lid tends to open, there is no traction on the conjunctiva. And this child fortunately had a very good outcome. Vision was maintained at 20/30 and the intraocular pressures are digitally normal. It's almost about 7 or 8 years since this boy had the surgery done, and he's doing very well. When do you do a posterior incision? So when I say posterior incision, basically the scarred conjunctiva, if you see this from the limbus, so this is again a one-eyed patient, elderly patient with a uveal coloboma, multiple vitreoretinal surgeries, including a scleral buckle, AGM allergy, and very poor ocular surface. So if you see the picture here, the conjunctiva is scarred from the limbus until almost 7 millimeters behind. There's absolutely no conjunctiva. So the implant was fixed posteriorly, but as you notice, when I was trying to dissect anteriorly, it was not possible to dissect. And I used a 11 number blade to dissect the episclera and the sclera along with the conjunctiva. So that is also possible, so that you don't have a buttonhole of the conjunctiva and worry about problems related to that. So it's very important. When you have difficulty in maneuvering the conjunctiva, there is nothing wrong in trying to assess the tissue underlying. And since this patient had good scleral thickness, it was quite easy for me to dissect out a part of the episclera and the sclera along with the conjunctiva. And I was able to place the tube very well. And of course, the additional patch graft was also used to cover it. This was 1 month post-operative period where the ocular surface is significantly improved and vision was maintained at 2200 and pressures were well controlled. Another lady, 51-year-old, again, one-eyed patient. If you see, all of these are post-vitreoretinal surgeries or post-keratoplasty eyes, where these are very difficult glaucomas that we are dealing with. High myope, multiple VR surgeries, a phakic, and this was an implant done elsewhere, and the patient presented with an extruded implant. If you just see this position of the implant, this is something that we should not do. Just because patient has a scarred conjunctiva, we are not able to place the implant properly. First of all, in such cases, we should not do it. If we do it, we'll have to choose a smaller sized implant and do a meticulous dissection as posteriorly as possible. And if we are using a smaller sized implant, in fact, we can try to fix it a little more posteriorly. So this patient had removal of that extruded implant and there was no conjunctiva absolutely. So we used an amniotic membrane over a corneal patch graft and covered it, and the eye healed very well. And this patient's pressures were obviously not coming down with a medication. So we tried to pull on with oral Diamox for a couple of months and later needed another procedure. So I'll just take you through the video of this surgery. So inferiorly is where, intratemporally is where we chose to do the implant. But if you see, there are hardly any conjunctiva there except the fornix. So I made an opening in the fornix, tried to fix a smaller sized implant, used a large scleral patch graft. The reason why we did that is, I said this is one-eyed patient. We harvested the conjunctiva from the contralateral eye. And since this was a graft over a graft, we need to be extremely careful when you are trying to operate such cases, because the conjunctival graft is very difficult to take up as a primary procedure, especially in these scarred eyes. So what I decided to do is use a large scleral patch graft, because in situations like that, even if the conjunctiva is gaping a little bit or trying to, takes time to heal up, you still have the sclera that is covering up the entire length of the tube as well as on either side, so that we don't end up having any problems. So this patient is doing extremely well. This was a 3-month photograph, but then I have this patient is followed up for more than about 10 years with me now. Vision of 20/100 maintained, she's a phakic, and intraocular pressures of 14 millimeters mercury on topical anti-glaucoma medications. This is another situation that we often face, that the conjunctiva is extremely scarred. So we have managed to place the implant, put the scleral patch graft, and I'm trying to close the conjunctiva. Very difficult to do a closure. So whenever there is a difficult tissue to handle, you should not try to force it, but you try and use on maneuvers, trying to mobilize the globe, reduce the traction by the speculum and all of this. Despite that, I could manage to somehow close the conjunctiva, but there was a small little opening in the conjunctiva that I noticed. I used a mattress suture. If I can just take you back here, I used a mattress suture and sutured it to the underlying sclera. and used an amniotic membrane to cover the tissue and used a large diameter bandage contact lens just to keep it in position. And this patient again, all these conditions where there is difficult conjunctiva to handle, I generally use oral doxycycline at the dose of 100 milligram twice daily for 3 to 4 weeks in the early postoperative period to prevent the scarring that happens and retraction of the conjunctiva or opening up the conjunctiva that happens in these patients. Another commonly encountered condition here is encircling bands. You realize that sometimes these encircling bands can be migrated anteriorly. And in situations like that, this patient had staphyloма all over the place, except for the inferonasal location where there was some good conjunctiva that I could try and manage. But because there was an anteriorly placed buckle, we need to be very careful in operating these eyes. Because the buckle is there, we shouldn't try and place an implant that is anterior. We have to try to dissect it out meticulously. All the adhesions have to be clearly dissected out. Like I said, again, when we use a smaller sized implant, we can try and place it even more posteriorly because you're not worried about the posterior edge of the implant going and hitting the optic nerve. So fix it as meticulously as possible, and the rest of the procedure should continue. Placement of the tube in the anterior chamber, the location, sulcus placement and the pars plana tube placement is something that I'll just take you through a couple of cases that are difficult that I had to handle. So this was a sulcus placed tube. And if you notice that the tube is present behind the iris and I was not able to see the tip of the tube. So sulcus placed tube, you definitely need to see the tip of the tube. Most often we encountered this when we have a large pupil, there is not much of an issue. But the pupil size is smaller, then you have a problem. So either you can take the tube out and redirect and make another incision, or try to redirect this tube itself by kinking the entry of the tube into the anterior chamber. So if you see that by kinking the tube slightly in the subscleral space there, in the subconjunctival space there, you are able to see the tip of the tube very well. So by doing so, you don't have to do this maneuver of making another incision there, and this would work quite well in these patients. Another way of managing this is if you have a tube that passes through either inadvertently into the, so this I wanted to actually place the tube in the anterior chamber, but it went into the sulcus. Again, I had already made a cut in the tube, so I can't obviously leave it in the sulcus. Otherwise, I'd have to do an vitrector, with the help of a vitrector, try to make an opening in the iris. So what I did through the existing peripheral iridectomy that was already present, use a Sinskey hook or any other second instrument that you have to try and bring it into the anterior chamber and position and try to suture it. So we can try and maneuver because it's not uncommon for us. Where you want the tube to go, most often it goes in, but then sometimes we encounter situations like this where you don't want it in a certain position, but we can try and modify it. So this was another young, very challenging case, a 14-year-old girl with keratoglobus. Other eye lost because of a trivial injury. And even if you see this, I also had almost about 5 or 6 sclerokeratoplasties done and a very, very minimal space in the anterior chamber left behind. So we chose to do a pars plana tube in this child. Pars plana vitrectomy followed by a tube insertion. So this is a common question asked again. How do you put in a pars plana tube? I don't use the tube with a clip. This is an AGV, and through a 23 gauge vitrectomy port in the superior-temporal location, I place the tube. But you have to see that although it is a 23 gauge opening, because of the thin sclera, the entry is not very snugly fitting. So always make sure that peritubular leakage does not happen and fix the entry with the help of a vicryl, and then you can do the rest of the procedure similarly. So this is something, improper placement of the tubes can lead to issues like corneal decompensation or tube blocks and multiple other problems that we deal with them, apart from the fact that subconjunctival tube erosions and implant exposures can happen. But I will just deal with a couple of conditions of the tube problems. So this was this girl that I showed you. 1 year later, until then it was working very well. She came with a flat bleb and a visible plate ridge, which means that there's absolutely no filtration that is happening here. Although I can't see the tube tip because it's in the pars plana, you can still make out that it is not functioning because the bleb is flat. Pressures were very high. And then we chose to do, actually we thought we'll take it up, do an endo-CPC if the tube is in any position that it is filtering, but for whatever reason it is not working. But then we realized that the tube was blocked with the peripheral scut of vitreous. So whenever the pars plana tube is placed, because they do a small core vitrectomy and clear up a little bit of space for us, but I think we should insist and tell our vitreoretinal surgeons to remove the base of the vitreous that is there, that is likely to block the tube at a later time point. So once we did that, her pressures came down. This was another patient who was referred to me following a DSEC. You see this tube was placed, and this was stuck between the iris and the cornea. So the pressures went up, and she was actually referred for a second implant. Doing a second implant is not difficult, but you will first have to take care of this tube, more importantly, because this is going to cause corneal decompensation at a later time point. Plus, we can avoid doing a second implant surgery in this eye. First of all, the graft eyes don't take the tubes very well, and I don't want to put in a second tube there. So what I did was, it is quite easy to actually redirect these tubes. The conjunctiva was opened up, and the previous scleral patch graft was also opened up. And so if you can notice, this 11 number blade is very, very useful for us to do a meticulous dissection. And the tube was taken out, and since this was completely blocked, there was no leak. So that was an advantage. And another entry was made, and the scleral entry was made, and this time the tube was passed into the sulcus. So it was quite easy to pass the tube into the sulcus, and this was refixed, and the same scleral patch graft was used to cover the tube, and the conjunctiva was closed. This is the post-operative period. You can see the tube is very well placed in the sulcus. So this is a pseudophakic eye, and vision was maintained at 20/80, and pressures were very well controlled. So we also should know when not to do an implant. Sometimes we have to understand that the eye itself is very difficult. This was a very young boy. He was a software professional who developed a Stevens-Johnson syndrome following use of topical Ziplox eye drops. So this is something that's extremely rare. I haven't seen any patient like that before, with that topical medication causing so much of a problem. He did have secondary glaucoma. So in fact, I thought we would be able to manage to do an implant, and then he was actually going in for a keratoprosthesis at a later time point. But the conjunctiva was extremely fragile, and they are very dry, and they have a lot of problems. So we did an endoscopic visualization of the posterior segment. Disc was quite healthy. He underwent a vitrectomy, and we decided that we'll do an endo-CPC to maintain the pressures at this point in time. And then he later underwent a type 2 keratoprosthesis. So we should know when not to do an implant and when you are likely to get into trouble. A couple of learnings from Adi. Ligating the tube completely to prevent early postoperative hypotony is extremely important. This is one step that is different compared to that of an AGV. While doing so, we need to be meticulous in the ligation. This is one such patient. In fact, I was telling my fellow that you need to be very, very careful when you're doing this. Otherwise, your tube can snap off. So you see that there is a problem here. When I was trying to ligate the tube, the tube was not fixed very well. The posterior fixation was not done properly. So because of which, when I was trying to do the third knot, actually the tube broke. Okay, so what we need to do is, what I do now is I place a posterior fixation suture here, and then make one ligature, two ligatures, one ligature in the middle of this box and the one posteriorly. So the reason why you do that is because the tube is not in the air, and you're not applying undue pressure over the tube when you're trying to completely ligate it. Tube fenestrations definitely are very, very helpful to overcome the early postoperative high intraocular pressures. And what do? We use a 10-0 nylon needle to go and open up the so 2 or 3 fenestrations is something that I do. And most often that is anterior to the ligation. And they work quite well. This was one such patient where I was trying to do a fenestration. This was a little longer fenestration, if you notice, and an anterior opening was made, and she was leaking quite a bit. And in fact, I thought I'll be able to manage by putting a scleral patch graft, but then later I realized that their globe was getting softer. So I had to go and ligate again anterior to this tube fenestration. So that's something that we need to be very, very careful about. So while we do fenestrations, which are extremely good to bring down the pressures in the early postoperative period, always assess if they are over-filtering or not, because that needs to be fixed then and there. Otherwise, we will end up having hypotony in the postoperative period. This is another problem. So Adi, especially the non-valid implants, since all of us are learning, post-operative sudden hypotony when the tube ligature opens up with a massive choroidal detachment is something that all of us dread, and we don't want this problem. So this was a child like that who presented to me 7 weeks post-Adi. So 6th week I had seen him, his ligature has opened up, pressures were 10, fantastic, and we were very happy. He went back and dad brought him to the emergency within a week, saying that his vision had come down suddenly. And so this child I had shown to the retinal surgeons, and they said we'll do a choroidal drainage along with the tube ligation. But by the time we scheduled surgery and he got a fitness for surgery, it was 3 days later. We had started him on oral steroids. Choroidal detachments slowly started regressing. So then we decided that since in children, this is something that you can actually see a dramatic response, we decided we'll just go ahead and do the tube ligation alone until the bleb wall thickens a little bit more, and then we can avoid doing the choroidal drainage in this patient. So this child actually underwent a tube ligation. Just make a small little opening at the junction between your tube and the plate, and you can just ligate it using a 6-0 vicryl or an 8-0 vicryl. I prefer to use a 6-0 vicryl, and then the conjunctiva can be closed back. So tube ligation is not very difficult. We can do that with a very small opening, and this child did very well. And you can see this 2 months later, vision had improved to 21-25, and pressures were very well controlled, not with any medication. So we don't have to lose heart. If you see something like this, the best thing is that you need to detect the problem early and to try to fix the problem as per whatever is the indication. This is a case from which I learned a lot. 85-year-old gentleman, a retired teacher, and a pseudo-exfoliation glaucoma, previously failed trab, underwent an ADI. So this was again 7th week post-operative period when he came back 6 weeks later, presented with very little vision and low IOP and flat anterior chamber with extensive choroidal detachment. And this patient also, which also, you need to understand, compared to the previous case, elderly people, choroidal detachment, for it to resolve takes a very long time, and sometimes may not even resolve. So we decided to do a choroidal drainage. You can see the amount of fluid that's coming out. And this patient, I wanted to do a permanent ligature. So I used a 3-0 nylon to stent the tube. We don't have the privilege of having the ripcord with us in India. So 3-0 nylon works well if it is a permanent closure that we require. And then of course I used a 6-0 vicryl to ligate the tube temporarily. And this patient, actually the tube is completely blocked now, but with medications, is doing very well, vision maintained at 20/60 and pressures very well controlled. And you can see the tube there, and you can see the ridge of the plate, which means that there is no filtration at all happening in this patient. So my contraindications to ADI, very elderly patients, pseudo-exfoliation, I think for some reason they do not have a thick bleb that forms, very thin penons they have, and that is one contraindication for me. Neovascular glaucoma, especially if they are post-transcleral cyclophotocoagulations, you need to be very, very careful. And one-eyed with very small central element of vision, I would prefer not to use it. So I would like to summarize to say that every eye is different. Preoperative planning is extremely important for us to choose the right type of implant, to place it in the right location, and to plan to place the tube in the correct position. Meticulous surgery is of course very important, but I think what is most important is try and do a modification that is necessary as per the surgery to have a safe and a successful surgery. So implants are quite useful. Know them, where to use, how to use them, anticipate problems. And problems, it's not that complications don't happen. They may happen. If they occur, we need to identify them early and treat them appropriately. Thank you very much for your attention.
Okay, thank you, Dr. Shirisha, for your excellent presentation. And a lot of videos you have shown, and very interesting and very complicated videos. We have learned a lot. And I'm requesting, we have a lot of questions like tube fenestrations and also ideal age of childhood glaucoma, materials for 360-degree trab. So I'm requesting Dr. Borun Kumar Nayak, sir, to tell something about your experience and also about this presentation. Sir.
Yeah, thank you. And Dr. Shirisha, it's really congratulations. Your presentation showed the experience, the vast experience that she has. And I'm sure not many get that kind of opportunity to have experience in such all variety of patients. So that way she is very lucky, and fortunately she is a gifted surgeon. There's no doubt about it, because she had whatever she has shown, and probably it was the gist of her, as she said just now, 2005, the first tube surgery she did, and in 15 years, she can now probably means you can manage anything through tube, any complication, and she can any problem, just consult and she will solve your problem. So thank you very much. and it's really fantastic. And I don't think she left anything to add, because whatever you could think of, everything was covered in that presentation. So it's really great job done. But one thing I must tell everyone, that whatever she has said, because she also has got backup of the big institution. So in case if she needs a vitreoretinal surgeon, then the help of vitreoretinal surgeon and the keratoprosthesis, all those things. So that way means probably everyone should not attempt whatever she has shown, but at least most of the thing, if you come across in your day-to-day practice, probably that will be quite helpful. So thank you once again, Sirisha.
Thank you.
Thank you. Thank you.
Great job done.
Thank you. Dr. Ronnie George, do you have comment on Dr. Sirisha's presentation? And you can share your experience too.
Yeah, so I mean, Sirisha obviously presented a lovely set of cases and her perspective on how to do things. I agree with her that on most of the points, except that I probably have I tend to use the Ahmed glaucoma valve more often than the ADI, mostly because we are a referral hospital where we don't have, just like Sirisha's center, where we don't have that much access to follow up. And patients very often, somewhere between 4 to 6 weeks or little around that time, land up with the ligatures opening. And that can become problematic. So I tend to use the Ahmed glaucoma valve more often, especially in patients with very high intraocular pressure where I need early control.
So, Dr. Sirisha, I have one question. If patient have a very high intraocular pressure with very advanced cupping, in that cases, if you do the ADI implant, the postoperative intraocular pressure will be raised, so because the tube is blocked. In that cases, the residual damage can occur and the patient may lose his vision. What is your experience about that cases?
Yeah, so like I said, fenestrations definitely help to bring down the pressure in the early postoperative period, because I've heard a couple of people ask me, if that is the case, do you ligate the tube not so tightly? Do you allow a little bit of filtration to happen through the tube? That we should never do. It has to be a complete ligation with absolutely no fluid that is leaking through the tube, because you realize that even if there is a minimal fluid going through, because there is no bleb there is no resistance otherwise other than the tube ligation, that should be avoided. But what can be done is we can definitely use tube fenestrations and of course cover them up with oral and topical anti-glaucoma medication. I had a situation where this patient was allergic to oral anti-glaucoma medication, cannot use. Topical medications he was terribly allergic to. So that was the reason why we took it up for surgery. In a situation like that, then you are really caught up. And I would say that in situations like that, don't even attempt. We can do an AGV. But you can tell me early postoperative IOP reduction may be great, but late postoperative pressures do go up because of the thickened blebs, and they may need to be put on topical or oral anti-glaucoma medication. So it's a double-edged sword. But I think we need to understand, relate to not losing vision versus managing the difficulties that we have. So with the non-valved implant, the problem, Professor John Brooks would disagree that they have an advantage of using a ripcord. So you have, even if the ligature opens up, they don't have that much of a worry because they have another extra stent that is there in the tube that will allow little bit more control, and then you can remove it 3 months later, 6 months later, 8 months later, whatever. But then we have to be very careful when you're not using any other stenting in the tube. So in situations like that, I would use an AGV. But if I have to use an ADI for whatever reason, then I would definitely do fenestrations and make sure that the post-operative period, they are covered with topical or oral medications.
Thank you.
Can I just make a comment?
Yes, Dr. Vanita, please.
See, I do have a great experience not only with bowel but also with ADI, and I feel some of the problems that are being faced can be easily overcome. I will just demonstrate with a video of Sturge-Weber syndrome, whereby I did not just multiple ligations at primary surgery, but also this young girl, unfortunately, she had a failed trap done by someone else and then referred to me. you can see the trap site there, and she had multiple nevi in her eye as well. When the conjunctiva was opened, the superior, isolating the superior rectus was a little bit difficult because of the scarred bleb there, but it was done. I do not open a tube or a plate until I can actually dissect the vessels. If I can't, then obviously I will do. So what I do is I actually prepare the plate a priori. I don't actually anchor it. First and foremost, I ask someone to stabilize the plate, as you can see there, and use multiple ligations. None of these ligations are going to open same time, same minute. That is the most important thing. Then I did a third one in this Sturge-Weber case, who was also given oral propranolol in the perioperative period. And then, of course, I use fenestrations. I use the same 6-0 vicryl. Sometimes I leave a stent as well, a vicryl stent. Now, these are all overcoming, problems that you may face, and you check for the filtration before you actually insert the adi in the tube. After this, of course, is the same. So in this particular case, this girl, very fortunately, I will not show you the rest, very fortunately had 13 pressure at 1 year, and she was not on any medication. So adi actually has, comes with a huge baggage, adi or bowelt, whatever. But actually, if you know how to manage it in the situation that you're using it, then in the long run, I feel it gives much better pressure outcomes than an AGV ever will. With AGV, you have to continue with medication. With adi, in my very own studies, I have proven that up to 60%, you don't need medication. So it definitely is much, I have to not being able to stop the share now. Yeah, here we are. So just a little bit of my experience in non-val, sorry, very sorry. Oh. Yeah, Shams, go ahead.
Yeah, I would like to ask questions. May I?
Okay.
Yeah.
Yes.
Yes.
Yeah. Thank you. It's very fantastic presentation, Dr. Shirisha. I would like to ask about the adi implantations. Yeah, I never used that implant, but I would like to ask whether why you not using for the advanced glaucoma.
So very advanced glaucoma, when I said, let's say has very small central island of vision, has about and things like that. So what happens in these patients is that although hypotony happens and it recovers, these patients, because of this advanced glaucoma, small central island of vision, it's possible that that hypotony itself can bring about a wipeout, and you definitely don't want to take a chance in that. Especially one-eyed patients with very advanced glaucoma, I don't want to take a chance. It may recover surgically and anatomically, but if you lose that vision, then I think we cannot bring it back. So I am a little scared and I'm a little conservative. So I would
even though you tight is very, I think if you do tight many times, so, but hypotony, it might happen.
Hypotony may happen. So hypotony definitely happens much more than in an AGV, we know that. But the worry is that which is that patient who may develop more hypotony and which is that patient who may develop lesser hypotony is something we cannot predict.
So you prefer to do with the Ahmed instead?
Exactly.
Yeah.
So Dr. Vidya, what you used to use, Ahmed or Beerholt?
Yeah, Ahmed. I usually use Ahmed instead for that all these patients.
Okay, Professor
but
John,
I use also Barfeld. Yeah, I use Barfeld, either Barfeld or Ahmed in my clinic.
Okay, Professor Brooks, do you have? Can you please explain where you use the Ahmed and where you use the Beerholt?
So Nowadays, I would really always use Baervelt tubes. Early on, I would use arm-made valves in certain circumstances. For instance, if follow-up's very difficult, so if patients travel from a long way away, they can't get back for regular follow-up. Because we use the stent suture within the lumen of the tube, which in most cases does need to be removed. If it's not certain whether patients can return for further surgery, an arm-made valve had a lot of advantages because you did the surgery, and if you never saw them again, a proportion would still be working. But as time's gone on and I've seen the results of arm-made valves, there's very little that can be done post-operatively apart from adding drops to get them working. And I think there's so much more that can be done for Baervelt tubes to adjust the pressure. And we have to wait longer for the tube to start draining because they're ligated. But if you look at them long term, the pressure always seems to be lower than with the arm-made valve. And the period with which they continue working is always longer. And so I always get much better results with a Baervelt tube compared with an arm-made. So they're very rare nowadays that I would use an arm-made valve. Baervelt tubes do take a lot more looking after. They're a little bit more complicated, as Dr. Benita's just mentioned, but I think it's worth it in the end because you do get better results from them.
Thank you. Dr. Salma, do you want to tell anything? I think you have one question.
Thank you, all the three speakers here. They are very experienced, very excellent surgeon, I must say. And we learned a lot today. This is a very excellent webinar today. I have one small question to Dr. Shirisha. You always use the scleral patch to cover the tube, or sometimes you use the patient own sclera and make a tunnel and cover the tube. What is the experience? You have any experience without patch graft with patient own sclera to cover?
Yeah, we can do either procedures, and I think a recent study that was published by George in American Journal of Ophthalmology, they had actually compared the two types of techniques. They used the long scleral tunnel as well as the scleral patch graft, and they found that the results were IOP control wise there is not much of a difference, but in those with scleral patch graft, incidentally they had 2 or 3 cases of tube exposure versus the ones with patient's own sclera, they didn't have any exposure. We can argue whichever way, and if you can say that, okay, in my country, I don't have a scleral patch graft available, what do I do? I think whatever works best for you is good, but one word of caution when you're using the patient's own sclera to make a tunnel, make a long tunnel. The tunnel should cover the entire length of the tube. That is the bottom line. So it should be 6 millimeters, 7 millimeter, whatever is the length of the tube that you have, the minimum is 7 millimeters at least. So we need to have a long tube. It can make a long tunnel, then make a small, you need to bring it out and then make one more tunnel so that the anterior entry into the anterior chamber or into the sulcus is again snugly fitting. So that's the only point I would like to add. Whatever works best for you is fine.
Thank you, Dr. Shirisha. Thank you all the speakers today. Thank you.
Thank you, Dr. What about Dr. Ronnie? What is your experience about the patch graft or self-sclera or tutoplast? What you are using?
We actually using corneal patch grafts, not scleral patch grafts, because they tend to erode much less than even a scleral patch graft. But I prefer to use a patch graft in every single patient because I personally feel that leaving it uncovered or just covered with conjunctiva is too much of a risk. One of the issues with scleral patch grafts also, scleral patch grafts sometimes melt, but corneal patch grafts, partial thickness corneal patch grafts practically never melt. So if you have access to tissue that your corneal surgeons don't want to use, that's possibly the best option that you have.
Thank you. So it depends on the availability of the cornea and actually. So do you, Professor Jakiash Wadu, do you have any comment about your experience or anything about the tube implant, what Dr. Shirisha has presented?
Actually, no, I have no comment. I mean, all the presentations were very self-explanatory and excellent presentations. I just had one question to any of the faculties or panelists. Regarding the advanced glaucomas where there is only a central island of vision, from their experience, would they recommend tube implant or a trabeculectomy? I mean, AGV versus trabeculectomy. Which would work better, or which they feel is safer for the small central island of vision regarding post-surgery hypotonia and everything?
Okay, excellent question. I think you can tell one by one. Dr. Vanita, please.
Yeah, thanks, Zakia. See, what I would suggest is, if it is a primary glaucoma, I would still do a trabeculectomy first, generally speaking, but, it all depends on the situation. However, even if there is a small central island of vision, and I have done many such cases with ADI, with the background of, hypotony and choroidals, believe me, if you prepare the plate a priori, good ligation, checking of ligation, that it's completely occluded, and not using just one ligation. Use 2, use 3, no problem. Okay, they don't always open at the same time. So the pressure reduction is also gradual. You do not get pressures down to 0. So I don't feel that it is a problem, but if you ask me, generally speaking, I would do a trabeculectomy in primary glaucomas first. If they are secondary glaucomas, then I would think about a tube first rather than trabeculectomy. So generally speaking, but of course, it all depends on each individual situations.
So 2 questions actually to Professor Jones. What are the materials you're using during 360-degree trabeculotomy? And another question is there any chance of injury to the lens during 360-degree trabeculotomy? Dr. Professor Jones.
There is a risk of damage to the lens because the catheter is crossing the anterior chamber. So again, when I make the paracentesis and fill the anterior chamber with viscoelastic, prior to that, I'll always fill the EAC with myocol. So it just constricts the pupil, so the risk of damage to the lens is much less. And so far, I don't think it's ever been a risk or a problem to damage the lens. The other question was the material for the trabeculotomy.
Yes.
So the eye-track microcatheter is, I'm not sure whether it is a silicone material, but if you're using a suture trabeculotomy, the suture generally is a 6-0 proline suture. The problem about a proline suture is that you do have to watch the progress of the proline suture as you pass it round the Schlemm's canal. So you do have to use intraoperative gonioscopy to see the blue proline suture. So it's not deviating down a collector channel. With a microcatheter, because you've got the flashing red light, you don't need to use gonioscopy at the same time. But it would be a 6-0 proline suture.
So can you use EP7 Ahmed valve in case of childhood glaucoma? If it is,
yes, you can. I mean,
yes.
You can use EP7, yes.
Yes, no, not always EP8 because sometimes EP8 may not available. In that cases, we can use the EP7. So now I'm coming to all the speakers and panelists to tell a few words about this this webinar. So starting from Dr. Varun Kumar Naik, sir.
Concluding comment.
Concluding comments.
Yeah.
So you are muted. Yes, sir.
Yeah.
First of all, I must thank you for inviting me to this wonderful webinar. And the second thing is that all the speakers were excellent, and the topics, whatever they covered, means in all topics there was some message and something to take for everyone. Not that means it's even the specialists also, and the comprehensive ophthalmologist for all. So this was really a very good webinar, and I am happy that I am part of it. I was just made part of it. So thank you very much.
Thank you. Thank you. We are very much happy to have you with us. Dr. Zakia Wadud. You are muted. Please unmute yourself.
It's an honor and privilege to be part of this webinar with my mentors, Dr. Sirisha, Dr. Vanita, and so many learned faculties. I think everyone will benefit so much from this webinar, and seeing the difficult cases being managed always encourages us to go ahead and do the difficult cases. So I think it was very helpful. Thank you.
Dr. Vanita, please do comment. You are muted.
Yes. Yeah, thank you very much for inviting me. Thanks for being constantly in touch over Facebook. It was a great pleasure to be part of it. You learn something. You hope that others can learn something from you. This is what conferences, which are now in the form of webinars, are all about. Thank you very much for having me.
Thank you. Dr. Salma Parveen.
Thank you, Dr. Shams Mohan Naman, for inviting me in such a wonderful webinar. I thank all my gratitude, and I thank all the learning speakers and other panelists here. This is an excellent webinar, I must say. Thank you all.
Professor Brooks, so do you have any comment?
Well, thank you very much for the invitation, really. It's nice nowadays that we can do these webinars. I'm in the middle of a clinic and I can still do the webinar without traveling to Chittagong, although I did enjoy my visit there. You can always learn from everybody. There's always things to learn. And every time you listen to people, you always think, oh yes, it was very worthwhile. It was very well organized, Dr. Shams, so thank you very much for organizing it. And maybe next time I'll learn a few words of Bengali before I speak.
Yes.
Dhanyabad.
Dhanyabad. Some of our here, Dr. Vanita, she can speak in Bengali. I think Dr. Shirisha too, a little. Yes.
Yeah.
Yeah. Dr. Shirisha, please. She's very known face in Bangladesh. She used to come here several times.
Thank you very much, and it was wonderful to see everybody. And I think the webinars have actually made things much easier. You can sit at home and wherever you're in the clinic, wherever. But most importantly, you see that nobody moves away from the screen and everybody is actually very attentive and listening. Otherwise, you have a tendency to move out when somebody else is speaking, and we do definitely miss. I guess that's an advantage, and I definitely have learned a lot. And thank you again for conducting a wonderful webinar and for the invitation.
Thank you. Dr. Vidya?
Yeah, thank you very much for inviting this exciting webinar, and for all the speakers. I think they are very excellent, and then thank you. I learned a lot. They are very difficult cases, and thank you very much. Thank you again.
Thank you. Dr. Ronnie, please.
First, thank you, Dr. Shams, for the kind invitation. It was actually a pleasure to attend because I got to see a lot of old friends and see the sort of difficult work that they're doing. And you invariably learn something a little bit here and there that you'd like to apply in your own practice. And what was probably most interesting was all the interested questions that came out. Your audience was asking questions and they were interested in seeing how things are. And I think that's the biggest value of a webinar, when you have actually connected with your audience, and hopefully both of us have learned something from it. Thank you once again for the invitation.
Thank you. So I am requesting Professor Sharfuddin Ahmed, sir, to conclude the session. And actually, he's the game maker. He always encouraged me to arrange some webinars. And we have a lot of webinars and a series of webinars. This is our second part of this session of the glaucoma. And after 4 days, we have another interesting, I'm inviting you all. We have another interesting webinar on postgraduate education in ophthalmology in this COVID era. This is very important because in country to country, it is vary. So in the next session, Professor Namrata Sharma from India and from different countries, they used to say their experience of, about the postgraduate education in this COVID era. So I'm requesting Professor Sharfuddin Ahmed to tell something and conclude the session.
Okay, thank you, Dr. Shams Mohammad Noman, who is the main organizer of this webinar. Behind the, I was in front of the darkness. That is, I was the light of this webinar. Thank you very much. Thanks to all speakers, especially John Brooks from UK. He's with us, and he has a specialty with us that we have highly delighted, and also we have a soft corner for him as he is the surgeon of our Honorable PM. And that's why he is always with us, and he will be with us as because he also visited Chittagong and in Bangladesh, and I also visited Moorfield, and together we'll be in Bangladesh or in UK in future. Thanks for your nice presentation and with us today in this excellent webinar. And Bhanita and Shirisha, they have also presented very nicely from Hyderabad. UK, Hyderabad, Bangladesh together in today's presentation. Along with this, we got our some of the renowned panelists. Dr. Varun Kumar Nayak from India, he is the President-elect AIOS. Dr. Ronnie Jacob, Dr. Vidya, Dr. Salma, and Dr. Jakia Wadud. I thank all the speakers and panelists, and a special thanks to Shams Muhammad Noman for arranging this excellent webinar. And also I thank Aristovision who has supported us for this type of webinar. In future, I hope the third episode of this type of webinar, some of you will be also invited in future, and you will, if you can give us time, we will invite you in the next episode. I think today, this type of webinar has helped a lot to all the ophthalmologists, even who are practicing, and the future ophthalmologists who are the residents. They are also participating with us, and I hope it will be more than 5,000 participants with us, and along with the Facebook and other medias. And this type of surgeries, the angle closure glaucoma or the glaucoma angle surgery and the implants, there are some controversies. And I hope today's presentation has made many ones controversy in the solving position, or they will be in some solutions of their complaining and of their presentations, and also their old thought. I think today this type of webinar will help in future to all the ophthalmologists. I thank all of you for giving us time to this webinar, including all the speakers and panelists and moderators. Thank you very much. Thank you.
Thank you. Thank you.
Dhanyabad.
Okay, thank you.
Dhanyabad. Thank you, Dr. Rani.
Thank you so much.
Thank you,
Okay.
Dr. Shirisha, ma'am.
Yeah.
Thank you, Professor John. You are in the clinic.
Yeah. We have. He has given a lot of time.
Yes.
Yeah. Thank you.
Thank you. Sir.
ভালোই হলো Indonesia, Bangladesh, UK, India.
India. Yes, sir.
All
Yes, sir.
are together. So this
Noman,
is the
thank you
global
very
village.
much.
Ji,
Yes.
ji, ji, Appa.
খুব সুন্দর